I'd like to introduce her. She is Kathleen Volman. She is a critical care clinical nurse specialist and consultant, and she is the speaker for today's presentation. She's published and lectured nationally and internationally on critical care HAI topics and is well known within the critical care nursing community. Today, she will be giving a concise yet extremely informative presentation titled Microorganisms Everywhere, Tackling the Vectors of Infection to Reduce HAIs. With that, I'd like to pass it over to Kathleen.
Oh, thanks so much, Anthony. And I'm really excited to spend, while brief, very important time with you this afternoon. Just to let you know on disclosures, I am a subject matter expert on HAI reduction for the American Hospital Association. And in the past, I've been sponsored by these companies, and this is sponsored by a stethoscope. So I'm teaching, you're going to get objectives. We're going to talk about identifying the modes of transmission for the spread of microorganisms in the healthcare environment. So that then allows you as a clinician to be able to see how you can impact and reduce that transmission. And what key evidence-based practices do we need to incorporate in order to reduce the bacterial load in our environment, to reduce the spread of microorganisms? So it's important. I tend to always start with the why. The why really is the impact that MDROs, multi-drug resistant organisms, are having on our patients' lives and the cost to the healthcare system. And this is data from 2019, 23,000 deaths associated with MDROs, and you're looking at up to a $5,000 per stay, about $2.5 billion in treatment costs related to this. And then you can also roll into that the MRSA bacteremia components. And we had a good chunk improvement rate around 2009 to about 2014, but it's gotten very stagnant in that journey. So we really need to up our game on this and improve the process. When you look, let me go back here for a second. When you look at CDC estimates of annual cases of MDRO, so this was a publication in 2023, you can look at the various pathogens, and I suspect all of you are dealing with some or all of these in your clinical environment. Annual cases of hospitalized patients close to 1 million, the annual mortality, you're looking at 40,000 patients with a close to $5 billion cost. So the question is, why wouldn't you want to find a way to prevent this? And then when you're dealing with the transmission of these microorganisms, they lead to hospital-acquired infections, which for the most part can be what I consider an avoidable adverse event. And you're looking at a mortality rate of about 100,000 patients, which is comparable to a jetliner crashing out of the sky every day. And if the American public were aware of that, there would be a lot more focus on this. Estimated cost, again, in the billions, leads to increased length of stay, morbidity, and mortality. And the patients that are most susceptible are most acute or at high risk, the HEMOC population, the critically ill, and the immunocompromised. And I would have to say we're coming to a point where a good portion of the acute care patients in the hospital are immunocompromised. So in other words, we're talking heavy risk in this journey. So when we look at common rates of transmission, I like to call them vectors, because that's really what they are, vectors of infection. The hands and the stethoscope go in one bunch, the environment go in another, and the patient flora goes in. And those are your three big ones. And when they looked at this data about where the transmission is occurring, the patient's endogenous flora, that means on their body, in their orifices, in the new orifices we create, is about 40%. Cross-infection by the hands of personnel, which also includes the stethoscope, is about 20 to 40%. Antibiotic-driven changes in the environment, about 20%. And the environment itself is about 20%. So when we're looking at reducing transmission, MDROs and HAIs, there's really three big targets, and I sort of alluded to them: the hand hygiene and the stethoscope together, the decontamination of the environment, and patient decolonization. These are the three big ticket items for overall horizontal management of infection versus a vertical management of infection. We'll talk about that in a little bit. There are other things that we do. We also include contact precautions and isolation. We practice device bundles and antibiotic stewardship as a support to those three components. So what I want to do in the time that I have with you is really delve into those three components. The first being hand hygiene. We're all aware of the significance of this. One of my favorite jokes. I use so much alcohol hand sanitizer, my hands joined a 12-step program. Any of your hands feel like that? feel free to make comments in the chat box if you feel so that we're interactive. We have our first polling question. So Anthony's going to help with this. What is the average number of times a clinician should be cleaning their hand in a shift? And that's a 12-hour shift. Dun, 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 dun. All right, way to go for participating, guys. Love it. All right, so right now what we have is 50% of the individuals say 75 times. The group that said 100 times is correct. It should be 100 times in a shift. So clearly we're not doing it to the level that we need to be doing it. So thank you for participating in that poll. We know it is one of the single most important factors of preventing the spread of infection, and we do it, as you saw in your own poll, about half the time of the amount that we should be doing it. And we know through research, this is one of the most efficient measures for reducing gram-negative multi-drug resistant organisms in the intensive care unit. So what does the science say we should be doing with this? Well, basically, alcohol-based hand hygiene is your frontline decontamination because it is quick, 20 to 30 seconds, but we still have to do it right. And I'm going to talk to you about that in just a second. If the hands are visibly soiled or you have a spore forming, then we need to use an antimicrobial soap and water. And that's a 40 to 60 second. And not too many people spend that time singing happy birthday like they're supposed to. We also need to make sure that we decontaminate after we remove our gloves, that we have appropriately dispensed lotions to prevent cracks and fissures in the hands. And I'll tell you, if I was frontline at the bedside, I wouldn't be wearing any rings. I'd have my nails cut short and I'd have short sleeves on because there are so many things that we do that contribute to contamination in the environment. These are wonderful tools from the WHO. When we launched this and when we need a re-up, I tend to put these on the towel containers for people to see. But in terms of the visualization, we know that if this is done correctly, you can go from a 60% kill to a 90% kill. The question is, are people doing it correctly and what do they frequently miss? And you can take a look at this. The purple is the sometimes missed, and the green, you can see the thumb is one of the areas is frequently missed. So teaching people to do that nail scrub in between the fingers and finish with the thumb so that you get the full court press is an important component in making the right thing happen for hand hygiene. Now, what has 5.5 billion contacts a year that we don't pay much attention to? It is the stethoscope, which is why it's being called the clinician's third hand. The volume and diversity of the microorganisms on that diaphragm are the same pathogens that are on the hand. The contact is similar. The diaphragm comes into direct physical contact, just like our hands do. So it is clearly a transmission vector. And that's why it can be considered this third hand. So I have another question, our second polling question. How is your facility currently practicing stethoscope hygiene? Are you wiping down with a disinfectant such as alcohol? Are you using single patient stethoscopes, a combination of the above or other? And by the way, you guys are coming in We're almost to 50%. There we are. We're at 50% now. You guys are coming in pretty much as what I see around the country, where the majority of clinicians clean this with an alcohol wipe. And we'll show some of the challenges related to that in a minute. And sad to say, the previous guidelines talk about cleaning stethoscopes once a week. If they're harboring the same bacteria that our hands are, yeah, it's just not going to happen. So there's a couple of dirty secrets, and you've probably figured this out already. Stethoscopes are nasty. They're covered with bugs, and nobody cleans them. And by the way, you don't have to take my word for it. I mean, I have some research to back that up, but all you have to do is spend 30 minutes standing at a unit or a clinic and watch behavior, and you'll be able to know what is happening. So in terms of routes of transmission, this was a study looking at known MRSA infected patients, and it was a 3-month observational study where they looked at gloved hands, stethoscope diaphragm, clothing that touched the patient, and then they cultured those to see what burden they were dealing with. And you can see 52% on the gloved hand, 48% on the clothing, and 40% on the stethoscope diaphragm. So parallel to the other components that we pay attention to. And when we look at this study, there were 4 hospitals, 200 stethoscopes. The cultures were obtained from each stethoscope, and they recorded the results. What did they find? 83% of the stethoscopes were contaminated when they were in practice in the environment. Makes a huge difference. So the question is, there is a bizarre psychological principle that we believe we're better than we are. So when you ask clinicians how well do they clean the stethoscope, they're like, oh yeah, I do a good job of that. But when you really look at the research data on direct observational studies, cleaning of the scope between patients occurs less than 4% of the time, which is not good. So self-reported compared to what is actually happening. People are, self-reporting that, yes, I clean, but it doesn't correlate with the bacterial growth that exists on the stethoscope. So there is a complete disconnect. And this was a study looking at 104 cultured stethoscopes from doctors, nurses, and respiratory therapists. And there was no statistical difference between self-reporting cleaning frequency method or the presence of bacteria. So in other words, they said they did it, but the results showed that it wasn't clean. So if cleaning does occur, and you saw by your own answer, alcohol, does it even work? Well, there are a couple of studies here. The commonly used practice of reducing the contamination is only partially successful at modifying those microorganism communities that exist on the device. And this was a prospective randomized double-blind study where they took cultures from 100 stethoscopes used by medical personnel, 90% contamination rate prior to cleaning. Immediately after with alcohol, it was around 30%. And if it wasn't cleaned for 5 days, which the old CDC guidelines talk about a week, it stayed at 95% contamination. Cleaning after 5 days stayed around that 30%. So we're still not getting full reduction. So there is still transmission, significant amount of transmission occurring. So self-reported stethoscope hygiene rates are never accurate, sort of like if you were self-reporting on your own hand hygiene. And they're higher than actual observed rates. And the common cleaning practices that we use to reduce contamination are probably only partially successful in eliminating those really nasty microbiome communities that exist on our devices. So one of the strategies that we tend to use for this is let's use an isolation stethoscope. But can I ask the group that's listening, how many of you have found accuracy, and feel free to put it in the chat box, with using a disposable stethoscope? It is really hard to have diagnostic accuracy. And so there is a disc cover. This was a study comparing disposable stethoscope with your own stethoscope using a disc cover on diagnosis whether there were any misdiagnosis. And you can see on the bottom here, here's the cover, and I'll get into showing that a little bit more. And what they found is there was zero misdiagnosis when the stethoscope was covered versus using a disposable stethoscope. So we have diagnostic accuracy, and we have a way to be able to protect and have a cover that doesn't affect the acoustic ability. Yeah, and Keith and Laura and Ryan, yeah, they're appropriate for toys, but not caring for patients. So if we look at the new normal, what we want to do is how can we work it into our flow, make it easy to do the right thing. And basically, I wave my stethoscope underneath, I get a new cover, I take care of my patient, I take the cover off, and I'm good to go. So I've really made it as strong as doing hand hygiene, but for the stethoscope. Easy to use, neutral impact on your workflow, improves the stethoscope hygiene, and improves patient safety. So I'm going to leave you with a good quote on this part of the talk. Always remember, my child, only dead fish go with the flow. So basically what that says, if you continue to do what you've always done and expect a different result, yeah. So we have to change. The next area is the environment, and we have significant scientific evidence that is accumulated on the contamination of environmental surfaces in the hospital that play a role in the transmission and development of HAIs. Number of studies that showed if the room is not cleaned correctly, the patient can actually pick up the bug of the previous patient. So it's a 5 to 6-fold increase in risk. And so what does the science tell us to do? We need a structured cleaning process with checklists, with feedback, blacklight feedback loops, things like that, as a part of it. And we also need to make sure that we are using something called, more in the future, something called no-touch cleaning. What is this? Some of you may have heard of ultraviolet C or hydrogen peroxide. It's basically taking what you have terminally cleaned and then cleaning to a 99.9%, something that a human can't reach. And this is where the science is going. And they're actually looking at science of overhead lights and things that can do a continuous no-touch clean as a part of it. So remember, even if you're on the right track, you'll get run over if you just sit there. So the last component of this horizontal strategy of the 3 big guns is patient decolonization. What we have found through clustered randomized trials is that by bathing with chlorhexidine from the jawline down on a daily basis in the intensive care unit, compared with a non-soap and tap water bath, we were able to reduce MDRO infections by 23%, 28% HAI, bloodstream infections, and 50% of that was gram-positive, which makes sense because of the skin. And because this study also included a bone marrow transplant unit, they saw a 90% reduction in fungal infections. And that led to probably the biggest study looking at this on the patient flora component. 75,000 patients, 160 ICUs in 16 states. They had 3 protocols: swab the nose for MRSA, plate it, isolate the patient if they had MRSA. The second group was swab, plate, isolate, but also put mupirocin in the nose for 5 days and CHG bathing from the jawline down. The third was no swab, no plate, no isolate. Everybody got mupirocin for 5 days and CHG bathing from the jawline down. And that last one was called universal decolonization. And that was what showed powerful impact in reducing MDROs. A 37% reduction in MRSA infection and 44% reduction from CLABSI from all pathogens. Just so that you're aware, they did move this out into the med-surg area, testing the same components, and what they found, it's not beneficial for everybody to get bathed with CHG and everybody have mupirocin in the nose twice a day for 5 days. However, if you have a device, a medical device in the med-surg unit, then doing the mupirocin and the CHG bathing is beneficial. And the last piece is really how you CHG bathe. And what the data shows, and you can look at, this was a double-blind randomized trial looking at the penetration of CHG on the skin. And the method that kept the most CHG on the skin, which is where the science is a 2% impregnated cloth to make that happen. And just for those that may be interested, there was a recent study published in JAMA comparing naso-iodophor to nasomupirocin because of the antibiotic resistance, along with both groups getting CHG bathing. And they wanted to see if they were equal, and it did not show that they were equal. Mupirocin did a better job in overall infection reduction as a part of that. So I would ask you guys, when would now be a good time to do this? It's not enough for us to do our best. We've got to know what to do and then be able to do our best. So I'm going to bug out. No, I'm not leaving, but I'm going to stop now and open it up for questions.